Hello, I'm Dr. Doug Teller. I'm an addiction medicine specialist that works at Kettering Hospital. And we're talking in this segment about prescribing multiple drugs. Very often I'm asked a question that goes like this: are there medically necessary reasons for prescribing multiple drugs that act on the central nervous system? And the obvious answer is yes. However, it's important to recognize in this series we're talking about drugs that are reinforcing and have abuse potential. And within that context, we look at how drugs are prescribed for acute circumstances versus chronic circumstances. And furthermore, chronic circumstances can be broken down into those that involve malignant conditions and those that are non-malignant conditions. I think it's pretty routine, and physicians feel pretty satisfied with prescribing different drug combinations for acute or chronic malignant conditions. It's those chronic non-malignant conditions that can be very difficult to not only prescribe for, but to monitor. Another question is, what are the most dangerous prescription drug combinations? And again, the prescription drugs we're specifically talking about are those with abuse potential, reinforcing drugs, and even more specifically, drugs that involve the categories of opioids or sedative hypnotics. The sedative hypnotic drugs can be further broken down into two important categories, specifically the benzodiazepines and also non-barbiturate sedative hypnotics such as carisoprodol, or the trade name being Soma. What we're seeing is that opioid and sedative hypnotic combinations are rather routinely given out in chronic non-malignant pain conditions, and it's this combination of drugs that very often lend itself to hazardous use. A third question is, what advice should physicians give patients who are taking pills and possibly benzodiazepines? And I think the important thing here is to give the patient liberty to check in with the doctor, asking some important questions, such as, do you know who I am and what I have done before? And volunteering that information, and also feeling open to the physician kind of checking and confirming what their story is. Another thing that I would suggest the physician tell the patient to do is to remind them, are you checking in with the other prescribers that I might have? Furthermore, a physician would be able to do this in the context of a contract and agreement, and this will be covered in more detail in another segment. A fourth question is, what are the common signs of drug-seeking behavior? And I'd just like to say that there are many signs of drug-seeking behavior, but many of these are very, very subjective. And I'd like to suggest that if you just rely on subjective signs of drug-seeking behavior, you may put yourself in some embarrassing situations. Besides kind of our gut check level of signs, we should think about things about the use of tobacco, for instance, which is an addictive precedent and makes it more likely that the person will misuse any prescribed medication. I would also look to check in with the patient's family. And this is something that may be necessary in terms of an office visit to set up before the patient comes to the visit. Otherwise, it may be necessary to delay prescribing a certain medication until family can come together, because this is a very important medication combinations to be carefully monitored and get feedback from the family. Another thing that should be done, I would say, with routine is to get a urine drug screen to make sure compliance is what was expected, and also to see if there are any other drugs non-prescribed that are being added in the mix that could synergistically affect the prescriptions in a more powerful or negative way. And last but not least, we should always keep in mind that when prescribing opioids or benzodiazepines, other sedative hypnotic stimulants for that matter as well, I would check in with the ORS reporting system and just to see if there are other prescribers and what past prescriptions have been like.